I had the time to be joining from this conversation, and I'm glad.
No worries, no worries. Oh, and let me a disclaimer to all, you know that I don't record it in Clubhouse, but I do record it on Zoom because I have the Zoom room open as well. So just FYI. But if you like me, you say whatever, and it is what it is. So how's it? Go ahead, Tara.
I was just gonna say, I know that when I went to the conference, they talked about inpatient and observation codes are changing. You know that the observation chart codes are being deleted.
Really?
Yes, it started in 2023. I think that's right. That those codes are supposed to be getting deleted.
So are they going to do something in place of those, or they just won't have observation?
Because you know, you got those consult and observation codes, like where we have to like learn to interchange them and everything, because Medicare doesn't take some codes, and you know we have to transfer, cross over.
Mm-hmm.
So my notes was that the ops charges will be deleted, consult codes will be changed, and the coding guidelines in this category are going to be totally revised. Yeah, so the medical decision-making table has been revised to support those changes also.
Interesting.
And with critical care, you know how we used to could build a EFM before that?
Uh-huh.
We're not going to be able to build an EFM before critical care. Right, if the patient was seen, if a patient is in the hospital, and say the hospital is around that morning, sees the patient and he bills a regular services, but then later on gets critical where they have a code and everything, he could bill both of those in any situation, but they're stating that they're going to take that away, where we're not going to be able to bill that before the critical care, and no matter what time of day, that happens. They're supposed to be taking that away where we can't do it.
Really? Wow. Interesting.
Yeah.
And I also wonder how that will affect. I wonder how that will affect or impact, like, I just lost it. Where they have the 2 midnight rule.
Well, I don't know. Well, because critical care, it's
not that part, the observation part. I'm sorry.
The observation part.
Yeah.
Oh, yeah.
Not the critical care.
Yeah, I wonder. I guess I don't know how they're gonna do this next.
Interesting. Interesting.
That's what they had said in the meeting, that inpatient and observation services are going to be changed in 2023.
You know what I've always wondered, like the entire time I've been in COVID, I've always wondered, our guidelines change and guidance changes, but we know that there are not enough CDI people, because physicians and providers, they're in a lot of places, their documentation is really not up to par. And with all these changes, like there's not really enough people to really guide them to help them navigate through. And I just don't know how that gap needs to be bridged, but it definitely needs to be bridged, because another thing that the people where I work now, I code charts for South Dakota, and the documentation by the providers, it's just I mean, when I read a chart, I'm like, why can't you just make a diagnosis? No, seriously, it's like why is it always this versus that? I mean, coming from when you work inpatient, if you have a consult and the doctor says one thing, the attending has to confirm it. It's not like you just take what they say. So that's where all this conflicting information comes in. And I'm just not understanding, or there needs to be a way where there could be education of the providers to make everything more cohesive.
So I read an article. Oh, I'm sorry. Go ahead.
Yeah, I'm really agreeing on this is and I think that some companies like ABC are focusing on that part. They are expanding their auditing services for the physician education part, and they wanted to make documentation more clearer. So yeah, some companies are taking it seriously, although they are doing it. I think they are doing it both ways as well as they wanted to make more something that will bring them money. But yeah, also they are taking the initiative, and I think auditing is gonna be the next big thing in the market of the revenue cycle as well as in the healthcare.
Well, from a compliance perspective, auditing should have always been part of that, and monitoring and making sure that the documentation is there and supports diagnoses and procedures and the like. I was reading an article about kind of along my vein with what's going on with the future of HIM, or health information. And they were talking about using computer assisted physician documentation. Have you heard anything about that? Yes. Yes. And so they're doing like artificial intelligence and putting together these. Well, actually, it's been kind of slowly rolling and moving in the background. It has been for several years, but it's kind of jumping into the CDI world. And to your point, Jesse, that you don't have enough CDI professionals, I think this is kind of the quote unquote answer to that.
Actually,
Go ahead.
yeah, actually, I think AI is one of the one of the aspects that there are many software companies and HIM providing companies that are looking forward. Even an year back, one of the CEOs of one company approaches me to help them in the coding part. They wanted to create a software in which, suppose patient before coming to the hospital or coming to the physician office, they will enter their data. They will just enter it down that I'm having cough and from 3 or 4 days, okay, and I'm on these medicines, okay. So that software with the help of the database and the database technology and the AI, it will give an provisional diagnosis to the doctor. So all the information will be already there. Doctor just need to see that, and the AI system will definitely wanna take it to the another level and give the doctor and what legal diagnosis the patient is coming with. So yeah, lots of companies are working on that.
Yeah. And it was talking about, I found the article, it was posted the other day, October 18th, in the ICD-10 Monitor. I don't know if you all read that. It's a great reference. But they were talking about how this AI software programs would help with some of the common queries. So things that you see all as CDI professionals that you see all the time. So you're not consistently or constantly asking the same question kind of over and over again to multiple physicians. And it allows them to kind of get an understanding and document real time versus after the fact. So I guess it will be some kind of notification or something in the chart, since, most hospital systems are on an EMR, that will pop up with the quote unquote query. But yeah, I thought this was really, really, really interesting how, and then it wasn't saying anything about like removing the CDI professional. It was saying it actually would free the CDI professional up for, at least on the positive spin of it, to free the CDI professional up for those cases that are more complex. And so where, you know, they would require more of their knowledge base and skill level to assist with, you know, assisting the provider with the query that they need to use for those types of scenarios. But for those like minor things that you see all the time, like that you're like, they don't get this yet, then the AI system would kind of take hold of those and use those. But then they were also talking about the whole compliance piece around it and making sure that if something like that is used, that they have the necessary oversight and monitoring activities to make sure that it works, and being transparent about things if they don't. So I thought that was really, really interesting, since we were talking just about the CDI program. But yeah, it's a lot. And then, you know, because that's one of the other things that they're looking at in the coding world too, is having some type of the coded computer assisted coding. And again, that kind of morphs the profession into more of an auditor role, because then you're kind of checking to make sure, or validating things versus actually assigning and applying the codes. So it's a little different spin on things.
Yeah, I think 3M is already almost there. I think they might be working on it. I've seen this software, and that sometimes, you know, the part that you told that the AI already does that. They read it from documentation, and it already says that the patient is having pain and abdomen, and they already show it in the suggestion section. So we can see a major change in the future, in the near future, I think, for the coding AI part.
Me personally, I'm a little less optimistic about the capabilities of AI, because I think it all sounds nice, but healthcare is complex, and at least for right now, like the experiences that I've had with computer assisted coding and any kind of like AI applications is they're very linear. It's similar to like a Google search where you put in cake, all kind of cake comes up, but all kinds of, you're not looking for all kinds of cake. You're looking for a very specific cake. So you have to sit through. And when you have people who have multi-system failure, and all these things are correlated, that makes it more complex. And I'm sure that at some point in time, AI will get to that level, but I just don't see it. And I still think that all that is still nice, but at the end of the day, you still need a provider to give you a diagnosis that is clear and concise, that has encapsulated all that information, all of that they have scanned through and read through into one diagnosis, or a couple diagnoses that this person has definitively, where there's no question. And I don't know if AI has that capability to do that just yet.
I agree. I don't know about AI stuff. It's just like, even with Epic, you know, like when a doctor puts in, like, you know, they look at something, it's just, they get this list and they just pick, you know, it's just like, you know, unspecified more than likely. So I guess what we're still supposed to, I guess, follow.
Exactly. I'm agreed with all that, but you know, from a very long time, you know, almost decades, we are talking about the good documentation, and some better ways to get a good documentation, but still, we are at the same point. So I don't think that AI could make such a big difference. But yeah, people might have been panicked in the healthcare industry just because of the transcription part. You know, in the medical transcription field, VRS AI technology has make it a little bit more easy for them. So yeah, definitely it led to an impact on the jobs of the transcriptionists. So that can be, just because of that, people might have worried about the
Transcription is linear. You're just repeating what somebody, you're just typing what it says. There's no decision making in medical transcription. And there's some medical decision making that you have to make as a coder when you read this information. Do I have enough meat to make this, to assign this code for this condition? That's the difference.
So in this,
Yeah,
go ahead, I'm sorry.
I agree with you.
Go ahead.
Yeah, I'm agree on that.
So in this article, it talks kind of to that where it mentions, it says that pretty much the system would kind of go through, where did I see it? It's used to scan the chart for clinical indicators, and then it would kind of put together a query for clarification to the provider. And I think it's something that probably more often than not is being pushed toward the physician or provider side of the house, because, you know, the complaints or the concerns that, you know, it's the inbox being full of queries is just an additional task or layer or of work that they have to do. And the selling point for this would be that these suggestions could quickly come up again while the physician is actually with the patient, because it's gone through and quickly scanning all of the patient documentation to come up with things that would help them in their documentation concurrently versus retrospectively. But I mean, I'm all with you guys. All I think about is iRobot when I hear AI and those things. But again, not that they're bad, but that's all I think. And how they could turn bad.
Go ahead, Sarah.
Oh, no, I was just saying, okay, well, you know, okay, if that's what it's gonna do, like pop up a, you know, like in Epic, if you do something and give you a hard stop or something, then, you know, all right, it's just giving them a little kind of hard stop to the jump or whatever. Okay, but I don't know about the rest of it.
Yeah, to quote the article, it's like presenting AI generated suggestions based on evidence within the chart while in the moment of patient care, with the information being quickly consumable with minimum cognitive burden, is far better than retrospective work, often coming days later and detached from the inline workflow and knowledge of the current patient condition. So that's what again, I think it's more or less a selling point from the provider's perspective.
I think that it's
But it could be a slippery slope there.
I just find HIM to be very interesting, and especially because I came into it after, you know, from being a nurse, and the interactions between nurses and doctors are nowhere near the interactions between coders and doctors, because it doesn't matter how much you query a provider, because when you get into clinical documentation, they talk about physician query response rate, because you can send all the queries you want, but if the doctor's not going to respond,
It doesn't matter.
it doesn't respond in time, it doesn't matter whether it was generated by a computer or by a code.
True.
And that's where, like, because the onus at some point there needs to be more education on physicians, because what I have found being a coder, right? Because I found being a coder that coders are well, most people outside of nurses are intimidated by doctors. Nurses don't give a crap, because nurses and doctors really go at it, you know, in day to day, whether people realize it or not. And most nurses are not afraid to assert what they know, or to challenge the doctor, or just ask them, what do you want to do? I need that. What you're saying is not clear. I've had doctors that wrote orders. You wrote the order wrong. I cannot believe you have to change it. So at some point in time, like, you know, the rubber has to hit the road, and these people have to start, documentation has to be better, and there has to be more consistency. And even aside from that, like another thing I noticed, even in coding, and like I, shared with you earlier, like I started a new job. I've only had one job in coding that had a coding man. I don't understand how you have a facility, how you have a department, and there's no coding man. There should be a system. This is what we do. This is how we handle this situation. This is how you handle that situation. Case in point, because by me being new, all my charts are QA, fine, no problem. The discharge summary said the person had acute metabolic encephalopathy. During one of the consults, one of the neurologists said toxic metabolic encephalopathy versus dementia. So the person who QA'd my chart said that you can't code acute metabolic encephalopathy. So I said, well, it's on the discharge summary. And so if the person is on it, the provider that completed the discharge summary is the person that oversaw this person's encounter. So that's supposed to be the definitive word. I mean, now that's what I learned in coding. I mean, is that not right?
That's right.
Yeah.
So that's what I'm saying. Like, there needs to be consistency. That there needs to be a manual, because I don't know how you can go back into an inpatient record and refute a discharge summary.
Right.
Without time, because if you're going to do that, you have to contact the provider. And we can't do that because they're inpatient. This is supposed to be home health. So there just needs to be a whole lot more consistency. Go ahead.
No, you're right, because, okay, speaking of that point of home health, because like, I worked with the hospital, and, we would do those, I would send out those G108, whatever codes. And, I had no idea what, I was like, they don't have anything in here, like the nurses needed stuff, and we had, the nurses would actually call up to our part of our office, and we would have to figure out, like, go and find our doctor and say, hey, the nurse said that, for home health stuff, and for her to bill it, to do everything. You're right on that part of it. Is there some miscommunication, some steps that needs to be fitted together on that part? On a lot of parts of coding, and I'm talking to the doctors. And with you being a nurse, like one of my friends is a nurse practitioner, and she has no idea anything about coding, any of that. She's like, we don't learn any of this. She feels like, she's like, there should have been a crash course or something when you first do all this.
Go ahead. That just made me think, similar to your point, Jesse, about some soft skills that coders need to have. So I'm like you, while I've never been a nurse, I've always just subscribed to, the doctors, I mean, they're human beings too. Like you put your pants on just like I do, and I'm here to help you. So I'm not intimidated by your degree or your title. I mean, again, I'm here as a resource, as a reference to help you do your job. And that's normally how I approach it. But I have seen auditors, I've seen folks that are coders that are so afraid and intimidated by the medical provider that, it's like, that seems like a whole training in and of itself. Like, you have to be able to communicate and talk with the team. I mean, you all are part of the same team and ultimately have the same goal, just in a different way. And so in order to ultimately, at the end of the day, help your customer, who is that patient, you got to be able to work together. And so I think that's probably a whole different training all in and of itself, is to give people the information and the skill to be able to assertively have these conversations with providers that, they're kind of afraid of.
I work with, like I said, with the hospital, if you work in and they were like, oh, okay, I didn't know that. Can you send me more information on it? And I'm like, sure, I'll email you, or you can come out of the office and I'll show you, you know, what you can and cannot do. And then I had one coder that I worked with, she would get mad because one of the providers, she, you know, I always had to send him messages, and you know what he told her though? I mean, and he, you know, being a provider, she took it wrong. I laughed at it arrogantly. And he said, well, my mistakes keep you with a job.
Wow.
But that right there, then I tell you, as a nurse, that would never apply, because what's supposed to happen is she's not supposed to take that on, because really and truly, the true response is, my job keeps you out of jail. That's as a coach.
And it's me, I said the same thing to you, because he was me, I could take him, he was nothing to me, like, but he was intimidated by him, but I sent him messages and stuff before, and we were fine, like, he was fine, he would answer my stuff, he would sign my paperwork, but I didn't take his little smartness or whatever, I laughed his stuff off, like, when he said that to her, and I was like, what, he made a mistake and you won't get paid. So, and that's why I'm like, you know, that's why CMS looking at y'all 3 now, you know? So,
And
I just was like, it was one of them, it was funny to me because it wasn't said to me, but.
I believe that it's not that global problem that each and every health is facing. And even though the accreditation companies like Joint Commission and everyone they're trying to, you know, align a lot and try to create some norms through which all the documentations would be in a same manner throughout the world. But yeah, it's only till the audit date. If we have audit of 1 week, that's only it's gonna be, you know, it's gonna be fine. Otherwise, things are not in a, you know, in the documentation part, it's not the same. And let's hope that, you know, there will be some kind of relief coming in the coming years, and that EMR part could be much better. That, you know, the diagnosis part could be more clear for us.
I don't have that much faith in technology, and I think that
Like you said, the steps that are supposed to be taken for the correction, I mean, that those are educational.
Right.
and case in point, like, for instance, like, I have not seen one echo report where the provider has diagnosed somebody. Now, they'll do all I can do that the offending aorta is dilated, or the aortic fluid is dilated. I have never ever seen a provider diagnose a person with aortic ectasis, because that's what it maps to. But as a coder, I know that the problem the provider doesn't know that that's a diagnosis, and that's what they should be diagnosing their patient. And they'll diagnose pulmonary hypertension all day, but not that. That's education.
Yeah, and they don't know.
Wow. Y'all all riled up this morning. Yeah, I think there's to everybody's point, there's a lot of education and training that needs to go around. Jesse, I'm with you. There should be a coding manual in every department. And I know things change. So you have some blank pages for those changes, but you should always have a foundation, a baseline. These are our expectations. These are what we need you to do. This is how you even get, even walking them through their systems or the systems that we're using, all of those things. And so every department should have that. That's wow.
What I have heard all week is, well, this is how I do it, or this is how I was trained to do it. Not this is what Stanford Health Policy says you do.
Right. And yeah, that's a compliance person's nightmare. Because you got all kinds of stuff coming in and there's no set standard consistent methodology in performing the task at hand. So yeah. That would drive me crazy.
That's my difficult because I am a stickler for order. Like I like what I have to do. I don't like things to change on the fly. Like that doesn't work. I like consistency and order. So that's why I love policy.
Yes, I do too. I'm all about the policy. And even if there are changes, then you make the necessary amendments to your policy. But you don't not have anything at all. Wow.
Exactly.
That is.
I got a whole bunch of HR policies. I got a whole bunch of those.
Oh, because that department don't play. And we should be just as diligent in we're dealing with a whole lot. We're dealing with a whole lot in our role in these organizations. And that would be the first thing I would ask. So where's your policy that says that you're supposed to do XYZ? That'd be the very first thing I would ask from a compliance perspective. Oh, well, we don't have a policy, and I just learned, and the person who trained me told me. I'm like, oh God.
Hello, hi, I'm Darcy here.
Hi, welcome.
I'm doing a PDR order. I'm a newbie to medical coding. I'm just starting to studying a student. So I have registered in AFPC and I started my. I was supposed to write my exam this year, but I postponed until May next year.
Okay.
So is there anything that I should be knowing? I would actually benefit from a coach or someone who could actually get me through this process. So I just saw this to be what to do and thought I might take help.
Jesse or Terry, I want to take that.
Say what?
I said, did either one of y'all want to answer her question?
It broke out, so I didn't hear the whole question.
Oh, I can. Guys, I heard the question. Once I answered, you can just repeat it so Tara can hear. But what I think, first of all, congratulations, and that's some luck to you. But I think that if I could give you any advice, the one thing that you need to be successful for your exam and for coding period is to know the coding guidelines.
Mm-hmm.
So you just start right there. You have to start with, as you are learning these chapters, as you're progressing, make sure you understand what are the coding guidelines. And they're in the front of your book, or you can go and download the current guidelines as a PDF, so you can have it on a tablet, so you don't have to lug your book around every time you want to read. And I would say start there, especially for ICD-10-CF. And when you're learning CPC, they have guidelines as well, but they don't have a PDF printout, so you have to read the book. But I would just say start with everything, learning the guidelines, because that will guide you in your sequencing. It'll guide you on how to code. It'll guide you on how to get used to thinking about how you want to process any question that you have to encounter. So I would say start with the guidelines. And as far as the coach, I think that maybe once you get closer to your exam date, because right now, if you're just starting, so you don't really know the guidelines. So a coach right now wouldn't be in your financial best interest, because you want to give yourself time to learn. Then you kind of want to have a coach to help you throw down and help you build up your speed as you approach your exam. That would be my
Right. I would agree with that. The guidelines is like the main key to everything. Like Jesse was stating was that being that you are just starting out, you know, get the feel of everything. But like once you get ready to sit for the test and know the test, make sure you highlight stuff in your book to make them pop out. Because with coding, you know, everything is the same by except for like maybe one word from, you know, where it's, you know, in or out, you know, from in the breaking a bone, just for procedure wise, like highlight that one word that make that one code different from the one that's above it. Or make a note like right beside it when it gets to that point where you're needing to, when you get down into the nitty-gritty of each chapter in the book. I think that helps out a lot when it gets to that point.
And I will echo the sentiments. Guidelines are your friends. I tell my students that all the time. Guidelines are your friends. I guess so my concern would be if you are, I know you said you're just starting the AAPC program. Are you taking the self-directed program, or do you have the program where you are actually having someone sit beside you? Because I know they have two different programs.
It's a self-directed program.
Okay, so I think you will need, I don't necessarily agree to wait until the end for the coaching. I think you will need some assistance to kind of guide you.
I wanted to do like fashion. I like everything with medicine and biology. I have a biology background, so I thought that would be interesting. I did finish the ICD-10 book, and then I like burnt out and drained out. Yeah, but I did well, but at the same time, CPT was kind of confusing. I don't know. Maybe I'm just tired.
Right. It can be. I totally agree.
Yeah.
It can be, and so that's where I'm saying if you don't have someone kind of guiding you initially to build that foundation, I think that would be helpful.
Yeah, you do need some help on that. Being that you're doing it yourself, I do recommend, like Sorry said, if you know somebody or if you don't know somebody, you can always email us. Jesse's great. I'm willing to always answer questions too if you need any help on anything. It doesn't help if you know somebody that can actually put it into real world versus just reading it. It makes more sense for somebody to actually examine it. Actually teach it to you versus you just reading.
Right.
Yeah.
Well, I sent you I went out and sent you a message, so you can feel free to with my email if you are.
Yeah, for sure. Yeah. So
I did a following. I'm following you.
Okay. And then you can always come here and ask a question or two. So we'll help in that vein as well.
I'm in the process of studying for the exam too. I've had a class and all that good stuff. Clarice, I reached out to you. Because I'm like so frustrated. But you can also go online and they'll have free practice exams too.
Yes.
Like you said before about the guidelines. The guidelines are posted online for free, and then YouTube too. You can go on YouTube as well. That's like be your best friend too, because that's what I'm in the process of doing right now.
Okay. Sure.
Yeah. Speaking of YouTube, when I was studying, I don't know if she still has it. Let me look and see this. I can't remember her name. It was like Miss Okay or something like that. She is amazing. With going through the books and helping you know what AAPC.
Yeah, I mean, I did not follow a YouTuber, but it was not that in detail, so I was looking for more of, like you said, solving the problems in real life, like that is the thing in APC which I have to finish before I get to the exam. I think, or parallelly that I should be doing is the apprenticeship, like it is the practical. But before I get that, I have to finish a lot more tests and assessments. So yeah, I'm just in the beginning. So I'm just trying to integrate. So I just want to know.
Yeah. Her channel is Miss OTOK coding channel. She's really, well, she's got 2020 on here. She don't have 2021 on here. But she does really good videos, and then I think if you look at some of her stuff, it helps out a lot.
Sure. Thank you so much. It was really helpful. And I found someone who can actually help me out because it was like I was lost in a jungle. It was completely insane.
Yeah, it can be overwhelming, and I always kind of warn people, particularly if they're doing kind of self-directed, is it's one thing to take that information, and it's totally doable. Don't get me wrong, it's totally doable. But every now and again, there may be concepts. It's like, well, what was that? And you kind of lose it, and so you still need to plug in to someone to assist you in that vein.
So the only thing that's bothering me is was when I finished my ICC consumer, coding is, I mean, like medicine is supposed to help people, but the coding or the insurance stuff, it doesn't actually seem to be doing that. And I already not that happy with American healthcare, and looking into this, it's like so. I could say disappointing to the level where the customers or the clients or the people are not helped. Instead, they are actually um, we are spending so much of money in insurance, but actually, is the medical system or the doctors doing their best? I don't think so. So I don't know. When they are talking about it, and pretty much as a patient, I feel like there's so much wrong with the diagnosis and the methods. So it really gets on my nerves.
Well, I think first and foremost is kind of what we have to work with, and that's the documentation. And then also keep in mind that the coding wasn't necessarily designed for reimbursement. It was designed for statistical analysis and tracking of the various diseases. I know the US kind of morphed it into what it is today as it deals with reimbursement. So it's kind of dual, but always in the forefront is an opportunity for us to make sure that we're telling the patient's story, their clinical story, through codes and the diagnoses and the procedures that they have. But again, we're bound by the documentation that the professionals or the provider documents. And so if there's lacking in the coding side of it, it's primarily due to the documentation that we are receiving on the provider end. And so even in our conversations, kind of working together and understanding that it's all in the team. The team, everybody has to do their part in order to get the end result and a great outcome for the patient. We on the business side of healthcare also kind of values our relationship with the team in doing what we need to do to make sure that our patients, because we feel like they're our patients too, that our patients are are getting the services that we're provided. But again, we're kind of, our hands are tied unless the documentation is there, which, you know, now we have other programs like we talked about earlier, like CDI and those types of things that will help in getting the best documentation we can out of our providers, even though it drives them kind of crazy that we're tapping them on the shoulder like, ma'am and sir, did you miss this? Or can you consider this? Or how about this? We saw this. Can you, you know, take a look at that? But at the end of the day, it's what helps our patients and provides their whole clinical perspective. So
Yeah.
my little soapbox moment, sorry.
Thank you so much for doing really sharing all of your input. Definitely let me do your email and all that.
Okay, definitely. And I too have some YouTube videos out there to assist. So you can feel free to go to my YouTube page, Professional Reimbursement Network, and check out some of the videos I have there.
And as we talk about CDI, you know, another point that I think, you know, gets left out of the whole conversation regarding documentation is that CDI people are most often are not coders.
Correct.
So they don't even have, so when we talk, we know as a coder what we want the doctor to document, but CDI people pretty much usually only work off of clinical indicators.
Mm-hmm.
They don't work off of, I mean, because when I took my CDI exam for the there were only two coded guideline questions and one CPT guideline question. So you could technically pass this exam without knowing anything about coding because it is not a coding exam.
Correct.
And I think that piece, I think that would really bridge the gap further. As everybody was talking, I was just thinking, if they require CDI people to not only be credentialed as CDI but be a coder, I think that would also improve the line of communication because then they would know exactly, because they're the person that's front facing with the providers. So they would have a bigger impact if they were coders to know what coders need.
Yep. That's a good point.
It is. So as a coder, how long do you work, or is that a different one? Is it a personal choice, or how is the work done?
It varies. It all depends on where you at and what you do.
Okay, so right now the minimum compensation, is that how would that be?
Say it again. I'm sorry, I missed what you said.
I mean how much we can be earned as a beginner?
To Tara's point, I guess it depends on the type of position that you're taking. There's some differences between inpatient coders as well as professional or provider coders. And there's some regional differences as well. So there's they do a salary survey. I think they do it every year, maybe every 2 years.
They just done it this week and they can finish by, I think, tomorrow or whatever.
And it kind of lets you know wherever it is that you sit and what you bring to the table, what the possibilities are, and kind of the averages of salary requirements. It's hard to say because you have all those variances involved. Anybody else want to jump on that?
Say it again, Tara.
Okay, go for it, Jason.
Oh, okay. Guys, the best advice I can give you is what I tell everybody who talks to me about coding, because that's the number one, that's the second question.
Yep.
Is compensation.
Yep.
And what I will tell anybody and everybody, and because I do it, I don't tell anybody anything, I don't. You have to know how to negotiate. And most people not the coders aside, most employees do not know how to negotiate salary because there's no such thing as we can't pay that. What that really translates to is we don't want to pay you that. And you have to come now in the beginning. If this is your first job, you will still have to definitely use your transferable skills. You have to know what other skills have helped you be a coder. Like you mentioned biology, having a biology background. So you have a lot more science experience than education than the average coder. So you have to talk that up. You have to do all your transferable skills about your attention to detail, and you will have to take the coding assessment. So you're going to pass the assessment in order to even get to the point where you're going to be talking about compensation anyway. So you have to use all those transferable skills, and you're going to do some research for your particular area. And because the regional salary differences do come into play, but a lot of jobs are remote. So if you have a remote job, you could live in Arizona, you could live in Oklahoma, but if your job is based on the East Coast, you're gonna make more money than a coder in Oklahoma.
Correct.
Because that's where the regional differences come in. And I just can't stress enough. Coders have to play up their transferable skills. But see, if you are an adult coming into coding, you have a whole lot of transferable skills because you had a work history. And in addition, and especially if you have a science background, you have to play that up. And I'll just give you a quick story. The job I have currently, it's a new field of coding for me, so I knew I was going to have to make an adjustment, and I was willing to. So when we got to when they made it an offer, I counted because I never accept the first offer. That's just me. So I counted. So of course they come back with less than what I requested because that's what they do. So I turned them down. I said, no thank you. I said, I'm not willing to budge. So I get off the phone. 3 days later, they called me back and they met my offer. You have to know how to negotiate.
Yeah, that is a very important skill. I have also HR experience. I was an HR executive, so.
Oh,
there you go.
Right, you know the game.
And I have a master's in social work, so I am a combination, but so yes, but this one, I'm new to getting an employment in the United States, but that is the challenge. So for me, even though my husband is a manager and he's done a lot of certifications, so yeah, definitely he'll be of help. And but this still is it's a new field to me, and yeah, that is why I need all the help I need, and I'm looking out for help from you guys. I mean, like, is there any organization that like regulates the compensation for medical coders? Is there like anything to do
Well, they
No.
they technically advocate that they do. Again, you have the American Health Information Management Association, or AHIMA, and AAPC. So both of those organizations try to, in some way or form, I think AHIMA more so than AAPC, advocate for on that level. But it's difficult for them. I don't know why it's difficult. I don't know why they're not necessarily at the table and having those conversations, particularly with HR professionals at these organizations, because it amazes me sometimes. I've even seen like ICD-9 on some job announcements. Like, it amazes me the disconnect, and why some of the HR folks are, they're looking the coding or HIM professional or HI professional, they're looking for a coder, or they're looking for someone with coding skills, but then the information somehow gets lost in translation when having the conversations with HR in order to in some organizations, not all, in order to actually post the job. And so it's like, well, you want this amount of information, or you want someone to come in with this level of skill, but you only want to pay them this amount of money. And that is crazy to me. So I think there is some discussion that needs to be had. They need to come together at the table and understand the benefit and the value that the health information professional, as well as, specifically the coder, brings to both the brings to the table, particularly for the revenue cycle in that organization. Because they need to have some conversations.
You need to say there is no union.
Oh no, ma'am, that doesn't exist.
So who should go, parents should make one.
Sorry to make
I should start the union. Can you see me as a union boss?
I think that, the connections you have, the knowledge you have, you can represent the coding association of the United States.
Do y'all know what happened to union bosses? No kidding.
United States is completely against the union. I don't know how it is.
Right. Right.
Move the United States, we can see that too.
I was actually, that's interesting that you say that. I was listening to someone talk about the value of unions today. And typically, in years past, they had a little more weight, but now that folks are kind of more individualized, and even to Jesse's point, you would come in and you would advocate for yourself to get, XYZ benefits and salaries and all of those things, versus having a union do that. And so I think because we're in that kind of space, it makes it a little difficult. And then to your point, I know I've worked with some organizations where unions were trying to be formed, particularly nursing unions, and it was so frowned upon. I think one or two of them got through, but you got to have some strong folks and some strong members that.
Capitalism here is a capital company capitalist. They hate anything socialist or something like that.
Correct.
That's really not true, because baby boomers have the money they have because of unions.
Amen.
So it's not, so the country does not hate unions. What they hate is, because it's all driven by capitalism. So what they did was, what this country did to break up unions was they shifted people, because it's all, hindsight is 20/20, because most of the people who were in union jobs, they were skilled labor.
Mm-hmm.
They were not white collar jobs.
Mm-hmm.
So the country shifted and they pushed everybody into white collar jobs because they were less likely to unionize. So now that everybody has these white collar jobs and they're no longer toiling in a factory, they think that they have arrived, but they actually have backed themselves into a corner. And I've been a nurse for 28 years, and I have been saying for 28 years that nurses, I was in another nurse group on Clubhouse, and they laughed when I said that nurses should have joined the team. But the thing is, look at what's going on now. Now you have so many nurses walking out on strike because at the end of the day, it's about money. And it's about
that's your union strategy.
Exactly.
Right. So they had a voice. They had a collective voice, bargaining and advocating for those workers. And I think there are some nursing unions still. I don't know if there's a collective huge national one. I'm not 100% certain. I've seen a few kind of sprout up. Like I said, with the previous healthcare organization, there were some up north, Northern Ohio, that were kind of strong. But that's something to consider.
Yeah, I think this, union thing is not about just compensation, right? I mean,
Right. It's the treatment of the worker. It's a lot. You're right.
I love that. Appreciate, right treatment, right pay, respect and all.
With all that, well, compensation is, we all go to work to be compensated. That was the main thing, with job security, safety conditions, all of that. So if, like nobody goes to work for free, because otherwise we'd be all be called volunteers.
I think this thing of self-advocacy, it doesn't work much, work well, like when you were talking about doctors, and, they do have an attitude. They do look down upon nurses, and I don't think they would even value medical coders as much. Like, it is, definitely it can be different individual person, but, I have, my dad was a pharma guy, and I've seen so many doctors all over the years, and there are so many doctor friends, and maybe they could just step on the knowledge we have or experience, and maybe they don't have the time, and it happens. Like, that is why we need an organization, that can actually collectively echo our voice. And I don't know, it's just my 2 cents, or I'm just a beginner, just trying to-
No, but that's great. That's and some fresh thought and ideas is something that I think our profession definitely needs. So I appreciate that.
I am definitely pro union because my father was a teamster, and I know firsthand because he was a teamster, we did very well. So I just think, and when we look at all of this, people want to talk about the great resignation that's going on now.
Yes.
All of that is frustration that has culminated from 20 plus years of this bad HR policy and this bad business. People are tired.
And then you have millennials that have, millennials and Gen Z or whatever is next. I try to stay current because my child is a millennial. But anyway, that they're not having it, and they're letting you know from the gate. We're not doing that. We're not doing that.
But it's also some silver foxes that are thrown in the town too.
Okay.
I mean, a lot of folks are going into early retirement. It is just, it's gotten out of hand. And, speaking of like nursing and unions, I've worked in hospitals. It is amazing how much money hospitals can come up with to fight their nurses unionizing versus supporting them and negotiating a fair contract. Because what they'll do, I work on a unit and I work 7P to 7A. The nursing manager and the VP of nursing will come in 12 o'clock at night and pull people aside, and they will give them a little vacation. They'll give them a raise effective immediately, just so they will vote against the union. And then as soon as it gets voted down, people end up getting furloughed. So it's like and then then the people who are left ends up being overworked. So they continuously shoot themselves in the foot, and it's because they don't understand the long term. Like, this is just they're just trying to get you to work in your against your own best interest. That's my 2 cents.
There's so much politics in the profession, but at the same time, and do you think for a beginner, remote working jobs are okay to have, or okay to start with, or does it depend on the location, or is that even more complicated? I mean, like, I would definitely do for remote working job, but as a beginner, would they consider giving you a remote job?
Yes.
Yes, they do. They have remote jobs for beginners. I can say I started in the hospital, and my position went remote. Only reason my position was remote is because our hospital was, growing so fast, and they needed extra office space. And we needed more coders. So instead of trying to find us more coders, they sent us out. Thank you, Jesus. But I also miss some of the interaction of being with people, because it can help you learn if you got the right group of people to work with, to learn from, versus being alone. It kind of like isolates you away, and you have to learn to make a team. It depends on who you work for, what company, or if you work for a company or a contract or anything, and you don't have someone to help you look at stuff if you got a question about.
I think that's a management issue. I think that's a management issue. That's a total management issue. And I think, unfortunately, there were lots and lots of negative things that COVID-19 presented to us. The benefit, though, was this whole remote work situation. And it's amazing to me how, just months before everything shut down, oh, you can't do that at home. You can't work at home. And now it's the quote unquote new norm. And I think there's a lot of the things that we do really could have always been done remotely. It's again right now as the end user and the frontline worker in those fields. I think we get it and we understand. It's management, because as a manager, you're taught the skill set, and again, it depends on your organization. Let me preface that. It depends on the organization. A lot of organizations kind of have the micromanagement style where, they need to see you, they need to check you, they need to what have you. And that's a little difficult. And it's a difficult transition for a lot of those managers in this new norm. So I think, and even Tara, to your point, a good manager will pull his or her team together. So you find ways to do that, and you find ways to disseminate the information that they need to do their job, versus, oh my God, I'm out here by myself, nobody can help me, who do I call? Your manager, it's about the manager. And I think there needs to be some this has been my soapbox all day. There needs to be some training on managers in this space.
We talked about that before. Like, I have a great group of ladies that are COVID, but we have poor management on some levels. So, but we already had that relationship first. So we talk, we do good. But I know other coaches that work in other departments or whatever that work from home, they don't have that. They don't talk to their other coaches. They don't want to. Or something. It really, it's all in that part of mindset. It's in that part of mindset. But even as it's starting out older, it just, like you said, it's in between Wednesday when if you want to be in the office or want to be at home.
I started out at home. My first job was remote. I've been coding now for over 7 years, and in those 7 years, I only had to go into an office less than 3 months. So, and whenever you start a job, it doesn't matter whether you've been coding for 1 year or for 20 years. You never hit the ground running. There's always a training period. There's always a QA period. I always want to make sure you get adjusted. And if you have any questions, so you won't, even if you work remotely, you're never by yourself. Never. Totally.
You're right about that. And then back to your original point, there should be a manual to help guide you through for that department.
That person that they tell you here, this is your person, your go-to person to help you with everything. Because, hopefully there's somebody there, like management.
Yep. They should put together a team for them. Yeah.
Clary, you hit the nail on the head when you were talking about managers and management style, because I have to say, like, the best company I ever worked for in coding was in Omaha. They're based in Bowie, Maryland. Mm-hmm. We had, under our quality manager, I was on several teams. Before I got on this one team, I could never understand why we were in meetings. And when I tell you, like, our teams were like 30, 31, 32 coders in a team. This man's team, accuracy-wise, every month was 98%, the whole team. And I'm like, wow, how is he doing this? Then there was another team, they were consistently like subpar. I ended up, as fate would have it, I ended up on both of their teams at different times. The person who had the highest accuracy score, he did it because he was the most responsive. If you had a question, he got back to you. And that's why, like, remote doesn't mean that you don't have any support, because technology in coding is like next level. He would be able to log into my computer, or I would, now you just share your screen. He would be able to read my review, and if I had a question, we would talk about what my question was and what would be the steps, and case go, and he would say, this is what the policy says we have to do. So that on his team, my accuracy was the highest it ever was the whole time I was with that company. Then fast forward, I get transferred to this other person's team where they're consistently, subpar. And I understood why. When I first got on this person's team, I was sent a 20-page PDF on how to send an email. I could not just email her. You had to have this way, you had to be formatted this way, you had to have this as the subject. And then when I would ask questions or email, it would go unanswered. So I understood, and it all goes back to management style and having the policy and procedure. So Clarice, you were spot on.
Yeah, that is, to me, that's the key. And you, in your experience, you can see the difference in the success rate. I see we have Sharon. I hope I'm saying your name right. And Kay, feel free to come on to the stage and introduce yourself and join the conversation. We're all family here. Welcome.
Hey guys, my name is Sharon Adams.
Sharon, I'm sorry.
Oh, that's okay. I stumbled across this morning. I was actually posting some things on Facebook, and somebody's notification popped up in Clubhouse, and I clicked on it, and as I was scrolling, I fell into the group, and I'm glad that I did.
Welcome.
I am a family nurse practitioner. I've been kind of listening to you guys, and my question is, I'm fairly new, and of course, we don't get these things in school of how to build, how to code. So, like somebody like myself that wants to get more in tune, because I'm in the process of doing my own thing, starting up a clinic. Right now, I've recently just started COVID clinics and testing and stuff, and my struggle is the whole billing and coding thing. So, what kind of guidance or information or suggestions that you guys may have for me as far as getting started, or do you suggest like maybe taking a course or something? What do you guys suggest?
Hiring a good biller and coder.
So I started out with that, and when I tell you, I got completely burnt.
A good one, a good compliant. Let's go back.
Sharon, I'm a nurse, well, I'm not a nurse practitioner, but I have a company called the Coders, and I have trained nurse practitioners. But when Tyrese said you need a good biller and coder, oftentimes they will not be the one and the same. You have to have a good coder and a good biller.
Correct.
Because most people cannot do both effectively. I know that's not what you want to hear, but that's really because you have excellent billers who are horrible coders. You have great coders who don't know jack about how to submit a bill for payment.
And they're different. They work together, but they're actually different functions of the revenue cycle. They need each other. They, front end and back end, but they just have different skill sets. But make sure they're compliant. They have some ethics and integrity about themselves. That's probably where you got burnt. But you also need to have some knowledge about the area in which you're practicing. So while I wouldn't necessarily suggest a full blown out coding or billing course, there's some resources. There are plenty of resources out there. Send me an email. I can shoot you some stuff that can kind of help you at least be able to talk the language to your coder and your builder, so that you understand and you're not kind of in the blind.
And yeah, you have to really say it. That's my thing. Now I'm stuck because I'm like, I definitely want to know what's going on, have some kind of place behind it, and I'm like, which one?
So, Sharon, who are your clients mainly Medicare, or are they commercial, or are they a mix?
I'm sorry, I had a call from the line.
Are your clients mainly like Medicare, Medicaid, or are they commercial, or is it a mix?
It's a mix.
Okay, because what you can do on your own right now is whatever state you're in, you can go on the state health website and you can download the Medicare, Medicaid manual for your state.
Mm-hmm.
You can also, since you bill Medicare, you can also find out what region you live in. You can find your Medicare administrative contractor for your region, and they can also help.
Mm-hmm.
Okay.
And also, if you're billing commercial, you need to know what that commercial contract says has to be billed and how it needs to be billed. That information you can find out on your own, and you should not, so you can empower yourself. That's what Bernice is talking about.
Exactly.
You don't have to take a billing and coding course, but you at least can go and find out because for instance, like for CMS, you can go right to the CMS website and you can download an Excel spreadsheet that shows how much the government pays for lab tests.
Yep.
Mm-hmm, mm-hmm.
And the other piece to that, especially on the commercial side and those contracts, is understanding and making sure that you are credentialed appropriately with those payers. That makes all the difference in the world in some cases.
I was going to add to Sharon that when you decide to get a biller, coder, someone to audit your claims or whatnot, make sure it's someone that is either local in your area or in the United States. Please do not outsource to someone out of the country.
Mm-hmm.
I have spoke to a provider, and this was a while back, and she was from California, but she was outsourcing from a different country, and she was stating to me that it was hard to get in contact with a real person. So keep that in mind. Keep that in mind too. And I think the reason why she outsourced to like someone out of the country is because it was quote unquote less expensive.
Mm-hmm.
So keep that in mind too when you're going through your process.
Okay.
And the one other thing I would add is make sure that the people that you have in your revenue cycle mix, make sure they understand and will follow up on your denials. Unfortunately, my experience has shown me that people lose a lot of money just on denials. And some of the denials are simple clerical typing mistakes. And you lost all this money because somebody transposed some numbers or some digits or something. So just make sure that you have people in your team that will also follow, and they can do the front end and or the back end, however, because I know starting out and doing your own thing, your resources are limited as well initially, but just make sure that you have somebody that's solid that will follow up with that so that you can continue to collect and keep the money that you're receiving.
And can I add one more thing too, Sherry?
Mm-hmm.
And it goes hand in hand with the revenue cycling. When you get a team together, make sure, because you want to see how, what's being paid and what's being not being paid. Have them generate reports for you.
Yep.
That's another good thing.
Yep.
Reports. Either monthly or 90 days or I would start monthly, because since you're just starting out, doing like a monthly report just to see what codes are being paid, what's not being paid, and then that, that'll show you like, okay, wait a minute, why is it 99213? What's going on here? Okay, there's no modifier, and then take it back to that person like, okay, you need to investigate this, and that's my other little flex for you. But good luck to everything for you. And I hope everything works out for you.
Yeah, and don't be afraid to also audit yourself. Have someone take a look. It's great to monitor everything internally, but every now and again, maybe once, twice, a couple years, you may want to have an external auditor come in and take a look at your stuff as well.
Great, thank you.
And to echo Clarice's point about denial, the sign that you are talking, or you will potentially have a good biller, is a good biller is going to automatically, when the first thing they're going to do is go through your denials, because you have a short amount of time for you to even file a denial.
That's
and
right.
That's money that's left on the table.
That's right.
So a good biller is going to ask you about your denials, and that's what they're going to work on first.
That's right.
Nice, okay. Thank you guys, I appreciate that.
You're welcome. You're welcome. So yeah, don't forget, you guys, this is normally I have a hard stop in an hour, but we've been talking, and so, I'll be here for a little while. Make sure you guys network. This is always a networking space. There's plenty of knowledge in the room. Even our newbies bring knowledge to the table. We learned all about unions today, Lord. That's a whole other conversation. But make sure, you all interact with each other, network with each other, and hit the little green Clubhouse thing to stay connected to our room, so that when we jump on. Usually we have the Saturday morning tea every Saturday morning at 9 a.m. Normally it's about for an hour, but the conversations have been juicy today, and I have some schoolwork to do later on, so that's why I'm still here. But just feel free to jump on in the room, and I always open it up to everybody to come on the stage. So even if if you're new to Clubhouse and never had the experience of seeing what happens on the stage and that type of thing, I always invite you to come in here, and it's a training a ground for you as well, so that you never know. One day you may want to open up your own club and have your own room, and at least you get a little knowledge on how to navigate that. And so I welcome that here. And also we answer, we discuss the coding world, now that we got Jesse and crew, the nursing world, compliance, and things, health information related. And if you are a student and new to coding, we also engage in assisting you in your journey as well, answering questions and providing resources. So, hey Kay, I see you finally came on over. Welcome. Okay.
The course, and I'm totally lost. I didn't have any type of human interaction. And like one of the speakers said, CBT really lost. So I'm just here as a sponge, open up everything.
Okay, well, welcome.
Thank you.
Welcome. Is there anything specifically that you wanted to ask, or?
At the moment, no, my background, just kind of going over and familiarizing myself.
Okay, no problem.
Some type of resources. That's all.
Okay, well, feel free to reach out to any of us, and we'll help in whatever way we can.
Thank you.
You're welcome. All right, y'all.
I think a lot of people have problems with CPT, and I know for me, I in my opinion, I figured out why CPT is so hard. It's not that the code set is hard, it's just that CPT is written and managed by the American Medical Coders, and doctors overcomplicate everything.
The key is learning the method to the madness. That's what it is. Trust and believe. There's a method to that madness, and that's the key.
Actually, maybe it's going to be a little complicated. CBT is straightforward, but
but, okay, I was gonna ask, are you a student, of medical coding?
I finished, sometime back in April, but like I said, I'm lost, totally lost.
So, no, I was just gonna ask, can we do some co-studying if we were students? Oh, that would really help.
I'm open, like I said, I almost gave up, but I paid my money and it's interesting. I want to get into it, but I just don't understand it, and I don't know anyone to reach out to or anything.
Okay, reach out to any of us. I will email you I'll send you a message with my email address, and if you know, want some encouragement, always it's like, that's one thing that I love to do, is to help on, when studying for the CPT and everything.
Absolutely.
Yes, we are here to help you.
Okay,
Yeah,
I'm one of those people, don't give up. I mean, I'm not confused or anything, but don't give up. I've had a class and everything, and like I said, I reached out to Clary about some things about the test. Don't give up. Because I was in the same boat as you, like, you know what, I might as well just give it. I'm never gonna be certified.
Yeah.
Don't give up.
No, you invested in yourself up to this point. Keep on investing, not necessarily monetarily, but get the information that you need and the resources to be successful. You've come too far. You got this.
Yeah, okay, I do want to help you out and we can help each other. I would love to have a group study or co-studying partner. So, please, the reach out to me if people would like something like that. And yeah, I'm open for that. Thank you.
Oh, can I be a cheerleader?
Oh, yeah, I would love that. I would love to have someone, got my back. It's really important because I am very poor. I have ADHD, I'm very poor and executive functioning. And I have 2 kids, so I get lost every day, managing, being a mom and stuff. So, and I'm just trying to get into the business. Yeah, so I would definitely appreciate every help I can. Yes. Thank you so much, you guys have been really
Cool.
wonderful.
Good.
Yes, thank you.
Good. Okay, well, I guess for the good of the room, I think we're we're all good. Again, don't forget to reach out with each other and network with each other. And I'll end today. Thank you all for joining. This has been great. I love it. Every week is a joy, and I learned something new as well. So now y'all want me to be a union boss. Oh, that tickled my spirit. But anyway, thank you all for joining. Have a great rest of your weekend. Remember my motto: don't wish for it, work for it. You all are definitely true living examples of that in what you bring to the table and your experiences. And I will see you all next Saturday at 9 a.m. All right, take care.
Yeah.